I'm a big advocate for office-based ophthalmic surgery. Here in the United States, we've got this distinction. There are surgeries that take place in hospital. We also have the second category of entities, these ASCs, ambulatory surgery centers. And there's this third place of service called an office-based surgical center. And office-based surgery centers here in the United States are relatively new. They're not so familiar to lots of doctors, but they offer some real advantages for the performance of lots of ophthalmic procedures. When I mention this to people, they think, okay, well, maybe some minor lid procedures can be done in the office, or maybe some refractive surgery, some LASIK, for example. But beyond that, what about for the really complicated cases? But the reason I'm making this video now is to show that actually it's not just possible for these really complicated operations to be done in the office, but in many ways it's preferable. It's better to do really complicated procedures in the office than in almost any other setting. And one of the reasons for that is the unbelievable amount of control that you have as a surgeon over what takes place in your office. If you have a dedicated suite set up for the performance of surgery in the office, that means that what happens in that room is under your direct control, which is unlike how it is in a hospital and even some surgery centers. Even a surgery center, which you share with other people, you don't necessarily control the instrumentation or the staff or the policies or so. But when you have things done in your office, you have this incredible ability to direct the flow, the cadence, the instruments that you use, the protocol and the procedures are all your design, and it can be optimized for your own patients and your own procedures. This is a patient that I operated on in the office just last week with a very complicated situation. This is a gentleman that had previously had a DMEC performed by me, but the outstanding problem for him now is he has a dislocated and tilted IOL in the capsular bag wrapped up with Summering's ring material. And the task we have here is an IOL exchange and Summering ring removal with a scleral fixated 3-piece IOL. And my preferred technique to do this is with a glued IOL maneuver. So we're going to show how this operation can be done in our office under topical anesthesia. So the way that the operation begins is we're going to administer a subtenon's block. What I like to use is 1 cc of subtenon's Exparel or bupivacaine, which is being delivered here. Then I'll make a peritomy with Westcott scissors inferiorly and superiorly, and then achieve some local hemostasis with a cautery. And this is actually really important to use cautery here because you want the bed dry and white and pristine so you can see what you are doing. For these scleral fixated techniques, I think it's so important to be able to visualize what's happening. So one key trick is to make sure that you have excellent hemostasis so the operative site is clean and clear to see what you are doing. Then we'll use this Ashvin Agrawal marker here to stamp the corneal surface and the sclera to show where these scleral flaps should be made. The glued IOL technique involves making these partial thickness scleral flaps 180 degrees away from each other, and this marker helps you to identify where those flaps should be positioned and the proper size for them. So it's inked with gentian violet, then stamped on the corneal surface. And I usually like then to dissect these flaps here with a 15-degree blade, and you'll notice I'm just outside of those purple marks. So the goal is to make a flap about 2.5 millimeters wide, right up to the limbus, down about 2.5 millimeters. So you should create a vaguely square flap of approximately 50% scleral thickness. So I'm just outside those purple marks. And then you sort of tunnel up and dissect under that flap. And another trick that I like to use is rather than using a conventional crescent knife, I like to use this mini crescent because it gives me better control over the sort of the fine depth distinction of how deep you are in the sclera. So I make a partial thickness scleral flap here and flip it over to reveal. That's about how deep it is. And then I mirror this on the other side 180 degrees apart. So the next thing I'll do is I'll make a sclerostomy at the base of these scleral flaps about 0.75 or 1 millimeters behind the limbus. And I do that typically with a needle of some sort. This is a 23 gauge needle, and that's probably a little small. Probably better would be something like a 21 gauge needle, because you want a large enough sclerostomy here so you can come easily in and out with various secondary accessory instruments. Because I'm using a 23 gauge needle, what I do is I go in and then I can just kind of wiggle a little bit with the bevel of the needle, and that expands that sclerostomy a bit. So I make it right up next to the limbus, about 0.75 or 1 millimeter back from the limbus, and that holds the IOL up high. And the reason that is useful is a more anteriorly positioned IOL. It turns out that that provides sort of better support if you're going to end up doing some kind of endothelial keratoplasty on an eye in the future. The Yamane technique, which I've spoken about on this channel before, is a brilliant innovation, but it ends up positioning the IOL a little bit down back in the eye. The IOL hangs back further in the eye, and that makes subsequent endothelial transplantation maneuvers a little bit more difficult. So here we go. These are these sclerostomies made with a needle about 1 millimeter from the limbus, 180 degrees apart, and you can perform vitrectomy through these sclerostomies. This eye has already been vitrectomized, so that's not necessary. Now I'm using a 3 millimeter keratome to make a corneal incision with my right hand. Now, I'm a left-handed surgeon, so this is a bit unnatural for me, but this is an important tip. If you're doing a glued IOL, it needs to have an incision made with the right hand kicked off a little bit to the side as it is displayed here. And the reason is when you inject the lens into the eye, you want to be pitching it in with your right hand and catching it with your left hand because of how the curvature of the haptics of the lens is arrayed inside of the eye. And this is much, much easier to do if you're delivering the lens from this sort of kicked off right vantage point than if you do it from a straight on position. So this was a key innovation that Amar Agarwal developed when he invented this technique, and it is very important and easy to overlook that you need to make the incision with the right hand off to the side a little bit. So here I am making a 3 millimeter incision, and the next thing I'm going to do is I'm going to use this phaco handpiece to try to phacoemulsify some of this Summerings material, which is floating around kind of loosely captured in this capsular bag. And ideally, I'd like to avoid dropping any of this into the back of the eye. So the material that I can easily access with the phaco, I'm going to try to phacoemulsify here with this handpiece. And I'm not going to be insistent on trying to remove it all, just some of it, okay? So now the key thing is we have an IOL in the eye, in the capsular bag, but it's still bound up in some of this Summerings material. And I'm going to show you here how to remove this lens from the eye as easily and simply and quickly as possible. These are IOL explanting forceps, which I'm using through this 3 millimeter corneal incision. And these are unbelievably useful forceps because you can use them to grab the lens and pull it out of a 3 millimeter wound without any intervening material like a lens cartridge. You can just grab the lens and pull it out of the eye without needing to cut the lens. And that is an amazing innovation because if you have to cut this lens in the eye, the visibility is poor. You worry about cutting through some of the capsular bag remnants and dropping Summerings ring material into the back of the eye. It's also a little bit fumbly and fiddly trying to, in a bimanual way, cut a lens and remove it from the eye. And it just takes longer. But if you can grab the lens and pull it in one piece out of the eye, that is so much quicker and easier, and that's what we are doing here. And by the way, let me show you 2 additional points here. Number 1, this is why it's nice to do this surgery in the office, because these forceps, I can just go online and buy them. I don't have to petition the ASC to buy them. I don't have to petition the hospital to buy them. If there's an instrument that I like, I can go buy it myself and use it tomorrow in my operating environment in my office. So it's this incredible autonomy that we have. Not to mention, we don't have to worry about these instruments being damaged if someone else is using them. They're ours, and so we take great care of them, and so we have this great certainty that we have the best instruments, we have whatever instruments we want to use, they're well cared for. That's the first point. The second point is I want to show you this lens which I've just explanted. Here it is, and you'll notice the haptic is bent backwards, and in fact I can kind of propeller it around. This is an important observation because this is a three-piece lens, and you might be thinking, well, why not just refixate the patient's existing lens in the eye? The reason we're removing it and putting a new lens in the eye is because I don't trust these lenses. When you have these lenses cockeyed in the eye from some previous surgery and there's some problem, it is often a good idea to take them out and remove them, throw them away, and get a new lens. That's something that Steve Safran talks about a lot in his YouTube videos. It's something I learned from him, and this is a great case in point demonstration of that concept. It's often good to get rid of that lens. And look, this Summerings ring material can just be expressed out through the wound. It's still more or less caught in the capsular bag, so you can just sort of delicately tease it out of the eye through that wound. And so this wasn't necessary to phacoemulsify. You can just pull it out. Okay, so now the patient's existing lens, capsular bag, Summerings ring material is out of the eye. It's time to inject a new lens. So here's a new lens. This is a three-piece MA50 BM lens made by Alcon. Alcon is a company that I'm not necessarily particularly fond of, but I love this lens. The reason I like this lens so much is that here in the United States, it's got the biggest optic diameter of any of the three-piece lenses. It's 6.5 millimeters. And a big optic diameter I love for scleral fixation for several reasons. Number one, it's more forgiving of decentration because it's so big. It occupies more space. That extra 0.5 millimeter doesn't seem like a lot, but inside the eye, it matters tremendously. I mean, 1/2 of a millimeter compared to 6 millimeters, I mean, that's like 10% more lens. It's, 10% greater area. And since surface area is the radius squared, it's actually a huge difference. It's a huge amount of more lens inside of the eye. And the other reason I like it, aside from forgiveness for decentration, is it provides a much bigger backboard if you're doing subsequent endothelial graft unfolding maneuvers like DMEC. It's much, much easier to do a DMEC on top of a scleral fixated MA50 BM lens than on top of any other three-piece lens. So I'm injecting the lens into the eye. I've got coaxial forceps through this little sclerostomy, and I'm going to pinch the end of the haptic, and I'm going to pull it out through that sclerostomy. That's what I'm doing here. So I'm injecting the lens with my right hand, and I've just pulled the haptic out with my left hand. Now I'm using my right hand to flex in the second haptic, and I'm going to reach in through a paracentesis now with my left hand, and I'm going to handshake this second haptic to myself. I'm passing it off, and then I'm going to reach in with my right hand through that sclerostomy, and I'm going to pull it out. And now I've got both haptics externalized, and look at this lens sitting in the eye. It's perfectly centered. It's enormous. It occupies a humongous amount of space inside of the eye. Now, the reason that Amar Agrawal likes this technique that he developed is that he says you can exquisitely titrate the centration of the lens by adjusting how much haptics you have pulled out of the eye, which is correct. What you do with these haptics is you make little scleral tunnels in the sclera with, in this case, a 26 gauge needle. And one key trick that we don't show in this video, I'm sorry, but what we normally do is you make this scleral tunnel with a 26 gauge needle, then you take a cyclodialysis spatula and you stick it through that scleral tunnel that you just make with the needle, and that sort of makes space inside that tunnel, and then you use curved tying forceps to grab this haptic and then feed it into that tunnel. That's what I'm doing here. And the amount of haptic that you feed in adjusts how far down and up the lens sits in the eye, and it also affects the centration of the lens if you tuck one haptic more than the other. So it gives you great on-the-table control of how the lens is sitting inside of the eye. The other thing is that you can adjust it infinitely right there with perfect visibility. You don't have to sort of cross your fingers and pray and hope that when you externalize this haptic with a Yamane technique that, oh, it's in the right place and you don't have to make another pass with the needle. I mean, you can just see what you're doing and play with it on the table. Now, this is tucking the second haptic. A lot of people in the United States don't use the glued IOL technique because they think, well, I don't have glue, I don't have access to seal glue. You don't need glue. The glue is not actually to fixate the lens, it's to repair the conjunctival peritomies, but it's also easy just to suture them, which is what I'm doing here. I'm just using 10-0 nylon just to suture up these peritomies. I don't suture the scleral flaps. I don't suture the sclerostomies. I just leave them like they are, and I just put these little sutures right here in the peritomies just to close them up. I'm also putting a stitch in the main wound just because it was a big operation, and I'll conclude the operation just by putting some air in the anterior chamber. So this was an operation that took me about 45 minutes to do, but it's a big, complex surgery. There are lots of considerations that go into it, but this patient was done in our office 5 days ago under topical anesthesia with sub-Tenon's block to accentuate the control for the patient's comfort. Patient wore his normal clothes into the operating room. He had breakfast that morning. He got up and just walked off the operating room table. And the key thing is that these big, complex operations, it's not just that you can do them in the office, it's that you have these incredible advantages. It's easier to do them in the offices. The surgeries are technically easier to do when you do them in your office as opposed to doing them in the hospital because you've got better help from your staff that you've trained, you have better instruments, things are more comfortable and familiar, the patients are more comfortable. So it is just shocking. If you are considering now thinking about, well, should you be doing office-based surgery and do you have enough of these minor procedures to make it worth your while? The real advantage of office-based procedures comes from doing the more complicated cases. That was the shocking realization that it's not just possible, it's safer to do them in the office because of the incredible advantages that redound to having better help and better instrumentation. If there's anything I can do to help you get started with your own complex office-based procedures, please let me know because, of course, it'd be our pleasure to assist.